Thank you for joining us. I'm Allie Wells, the Communications Director with the Foundation for a Healthy Kentucky. Before we kick things off, I just want to point out a few logistics. We've enabled the live transcript feature on this webinar. You can control whether you see that by selecting closed captions at the bottom of your screen. And if you have any questions during the webinar, just add it to the chat box and we are going to address all of them together at the end. With that, I'm going to turn things over to Dr. J.D. Miller, our moderator for this evening. J.D.
Welcome, everyone. My name is J.D. Miller. I worked for 33 years as a staff physician and project director for the Clover Fort Clinic in Harlan County, and then for 13 years as chief medical officer for Appalachian Regional Healthcare with hospitals in Eastern Kentucky and Southern West Virginia. I'm on the Community Advisory Council for the Foundation for a Healthy Kentucky. The organization's mission is to address the unmet health needs of Kentuckians by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. We are happy to have you here for our webinar, Health for a Change, Unmasking the Impact of Toxic Stress and Discrimination on Health Outcomes. With us today as our panelists, we have Dr. Timothy Anger, a clinical neuropsychologist and assistant professor at the University of Kentucky College of Medicine, Dr. Karen Krieger, the director of the Health Equity for the University of Louisville's Health Sciences Center, as well as the Foundation for a Healthy Kentucky's Endowed Chair for Urban Health Policy, and Dr. Shilpa Lundy, co-founder and executive director of the nonprofit Maternal Spotlight. We are grateful to all of them for spending their time putting together presentations on this important topic. Our hope for this webinar is that you will walk away with a good grasp of the following objectives: to understand the science of toxic stress, what leads to it, and how it can be a cause of chronic conditions; to recognize the health impacts and quality of care issues caused by living conditions and location; to identify the discrimination and biases that exist in common healthcare practices and existing guidelines; and to understand the potential opportunities to integrate patient-centered care. I am going to send things over now to our first speaker, Dr. Timothy Anger. He is a clinical neuropsychologist and assistant professor of neurology with the UK College of Medicine and the Kentucky Neuroscience Institute in Lexington. He focuses on applied neuropsychology and examining ways to enhance the clinical conceptualization of diverse populations and diagnoses. Resiliency and wellness is one of his many focuses for his clinical work and research. Welcome, Dr. Anger.
Good evening, everyone. I hope you can hear me okay. I think I figured out how to unmute myself properly, and I apologize for the contrast, but the sun is setting here in this part of Kentucky. I'd like to talk a little bit about toxic stress, and I want to be able to define toxic stress, discuss a little bit what some of the research that's come out about it, what kind of impact it has had, and then in the remaining time, discuss some of the conditions and some of the health factors that can be kind of exacerbated by toxic stress and the negative impact that it can have on not only ourselves, but our patients and our community as well. So it's important to understand that stress in general can be a good thing when it occurs in isolation. It is the mind and body's response to elements and events that surround us, and at its core, stress is an adaptive response. So I'll get into that just here in a minute. We've all familiarized ourselves, I'm sure, with the expression fight or flight, or for those of us who know a little bit more psychology, there's some other things affiliated with that as well beyond fight or flight. But it's a stress-induced reaction by our body that either prepares us to make egress from something or engage with something when we find ourselves startled or threatened. So with at least a modicum of stress, we may find ourselves vulnerable to any number of concerns, but the response is what prepares our body to act in these situations. But it's important to note that just as with everything, moderation is the key, and stress is no different from that. When you repeatedly cycle your sympathetic and parasympathetic nervous systems, which is what you're doing when you have a stress response, it can inadvertently have a heavier tax on the body than you may have anticipated. So just like when you're driving a car, you want to depress the gas pedal and the brake pedal with moderation and not just floor the accelerator all the time, because that's not how routine driving should work. And that can obviously cause a number of problems for your automobile. And in that same vein, leaving the pedal to your stress system floored all the time can cause problems for your body. So what stress is that toxic stress is the repeated or chronic exposure to that stress response without your body's ability to return to homeostasis. It can occur in all individuals, and it can be exacerbated by any number of health factors that can be present around us. Without having a steady grounding opportunity or grounding environment, individuals are at increased risk for developing and propagating chronic health concerns. There have been a number of studies that have looked at individuals who have the proclivity for numerous physical health concerns and psychological health concerns in the presence of toxic stress. That can begin as early as childhood, but it can really occur at any point during the lifespan. So again, that positive stress response can be a good, normal, healthy response to something. When you sort of approach not great, but tolerable health response is when you have more frequent, serious exacerbations of stress, but you are buffered by opportunities to sort of reestablish yourself and ground yourself in baseline. It becomes toxic when the response is prolonged, perpetually activated, and when you find yourself in the absence of the ability to reground yourself, restabilize, or when you're in an environment that is absent of appropriate levels of support. So what are some of the factors that can exacerbate this? I want to talk a little bit about a study, the ACEs study, the Adverse Childhood Experiences Survey that came out from the CDC. What they looked at was levels of toxic stress in children and pediatrics and how it was sort of exacerbated by factors in the environment and other variables in the community that can cause toxic stress in children. And these can be extrapolated to the adult population as well. And I want to read down some of these risk factors. And then after that, I want to talk a little bit more about the stress response and some of the adverse health outcomes. And that should probably eat up the majority of my time. So I'll try not to be so long-winded. Basically, what was determined for the childhood population was that the more adverse experiences that were experienced by an individual, the more likely they are to suffer from the outcomes of toxic stress. Several individual and family risk factors that were present in this population that were found to be related to significant stress health responses include when caregivers have challenges related to children with special needs, such as disabilities or mental health issues or chronic physical illnesses. Children or youth who don't feel close to their parents and feel like they can't communicate openly and honestly with them. Children who start engaging in higher risk behavior, including higher risk sexual behavior at an early age. Children who are more isolated or have limited friends group or who engage in even delinquent behavior. Caregivers who have a limited understanding of their children's needs or the appropriate developmental milestones or developmental needs that need to be met. Caregivers who were abused themselves when they were children, because the children then become at risk for being victims of the caregiver's own trauma. Single parent households, low income, lower levels of education and parenthood, high levels of parenting stress, high levels of economic stress in the home, corporal punishment, inconsistent levels of discipline, or changing households with multiple individuals who provide various levels of discipline, high conflict or negative styles of communication, and an attitude of just accepting or justifying violence or aggression, even if it's secondhand. So it doesn't need to be a household where there's violence that's visited upon the child. It could be a household where we just see that violence in general is accepted or celebrated when it's seen or observed or heard about. When you think about the level of impact that can have on individuals who are in homes with those level of structure, but also talk about how the reciprocal patterns that can be perpetuated when children grow up with those factors, then become parents themselves and are working through their own trauma. Those are risk factors that the research has identified to be contributing to exacerbations of toxic stress. As far as the community perspective is concerned, if the individual is growing up in a community that has a high rate of violence or crime, or if there's a higher rate of poverty or limited access to educational resource or economic opportunities, areas where there's high unemployment rate, communities with easier access to drug and alcohol, communities where neighbors don't know or don't look out for each other, and there's a low sense of socialization in the direct community, where there's fewer opportunities for engagement for children and community members to get involved, where there's potentially unstable housing or family members are forced to relocate frequently because of economic circumstances, food insecurity, and high level of social and environmental disorder. And I'm sure there are several opportunities across this state where we can look at certain communities and pinpoint several of these factors and how individuals could be at risk due to them. So the CDC didn't just leave us with all doom and gloom. They did give us some protective factors as well. Some things are sort of up to the community level, but some things are up to us as caregivers and providers. So when families have access to economic or financial assistance, when families have access to medical care, in addition to mental health services. So it can't just be medical care, but mental health services have to be part of that as well. When they have access to safe and stable housing or appropriate education, when they have access to safe childcare, preschool, programs and activities, family-friendly policies, community outreach activities, and partnership between community businesses, outreach from healthcare, government outreach, and other sectors, private sectors who become involved and take ownership of their community. It helps the residents feel connected and become involved. It helps taper the amount of community violence, increase exposure, and feel support. And those variables are linked to the reduction of toxic stress. So I talked about earlier about the stress response. So I'd like to get a little technical on sort of what that stress response look like and why it can be so problematic from a biophysical standpoint. So a normal stress response is when the hypothalamus in the brain senses that there are environmental factors that would give rise to a stress exacerbation, and it produces corticotrophin releasing hormone, which in turn stimulates the pituitary gland to secrete adenocorticotrophin hormone that then stimulates the adrenal glands to release glucocorticoids and catecholamines into the blood. So catecholamines largely facilitate our sympathetic nervous response. So that sympathetic response is pupil dilation, salivary inhibition, bronchial relaxation, heart rate acceleration, inhibition of peristalsis, inhibition of digestive secretion, stimulation of glucose production, secreting adrenaline and noradrenaline, and inhibiting bladder control. These glucocorticoids, in excessive amounts when they're released, they are integral to the immune response in the way that catecholamines are integral to the sympathetic response. And the way that they're integral to the immune response is that they help regulate bone health, bone formation, and immuno standards. So when they're seen in excess, in repeated elevated levels of stress responses, glucocorticoids can inhibit bone formation, can suppress calcium absorption, and those factors can contribute to osteoporosis. They can delay wound healing, they can cause muscle fatigue and weakness, and even increase the risk of infection and the development of autoimmune diseases. Glucocorticoids also act on the hippocampus, the amygdala, and the frontal lobes of the brain, which can cause emotional dysregulation, memory weaknesses, and prolonged exposure can even cause neurostructural changes and start to cause hippocampal destruction. Overexposure to them can also facilitate hypervigilance, in which memory can be impacted because we only at that point in time learn to encode memories when we are in peak vigilance and emotional arousal state, which is one of the variables that can facilitate an increased emotional response for PTSD level flashbacks and other types of emotional memories. So the parasympathetic nervous system is supposed to kick in to relax our pupils, help us salivate again, reduce the amount of glucose that's being emitted in the bloodstream, stimulate bile release, and return all the things back to homeostasis. But when we're perpetually stressed, perpetually in a heightened sense of stress, we overactivate our sympathetic response and we don't engage our parasympathetic response. And this prolonged allostasis is what establishes a chronic stress response. And this is maladaptive. It becomes problematic in children when they sense that the environment that they're in is perpetually stressful. The same thing happens to adults when we begin to associate our work environment or our home environment or our social environment with being on edge or stressful. And then we put ourselves into a sympathetic nervous system response whenever we're in those environments. In the realm of the forensic world, where we talk about the impact of toxic stress on burnout, the expression that I see used most of the time is go to work, get stressed, come home, get depressed. And that's the cycle we want to avoid being in, but we can inevitably fall into when we're in stress. The Yerkes-Dodson curve, which is a parabolic curve, does stipulate that there is a peak amount of stress response that is good, but that's when we're appropriately cycling through the sympathetic and the parasympathetic nervous system and not remaining in prolonged activation. When we do remain in prolonged activation, we trickle onto the downslope of that curve and our arousal and our performance levels decrease significantly. So some of the significant consequences, if you were listening when I was describing the impact that glucocorticoids and those other enzymes have on the body, can cause when you overstimulate the respiratory system, the cardiovascular system, the immune system. The health consequences of toxic stress include, and this is not an exhaustive list, but these are the most common: COPD, depression, early initiation of smoking. It can cause fetal death for pregnant females, low health-related quality of life, illicit substance use, ischemic heart disease, liver disease, risk of IPV, risk of sexual violence, STDs, smoking, even homicidality and suicidality, poor sleep, physical pain, such as chronic pain, migraine, headaches, etc., emotional dysregulation, memory difficulty, anxiety, social withdrawal and isolation. In fact, we've looked at brain scans that have shown children who are exposed to toxic stress levels from a very young age, specifically in this study, ones who are living in poverty. And we showed that by the age of 2 years, they had statistically significantly reduced neural connectivity compared to individuals who are not living in poverty and have lower stress environment. Some of the systems that are chronically impacted, if we look at the neurologic system, it can facilitate difficulty concentrating, increased anxiety and depression, irritability, mood disruption, brain fog, those reduced neurostructural connectivity issues, lower self-esteem, lower quality of life. From a cardiovascular standpoint, high cholesterol, high blood pressure, increased risk of heart attack, increased risk of stroke, tons of stress on the cardiovascular system because of the chronic peaking and spiking and dysregulation of blood pressure. From the immune perspective, like we said, decreased immune function and decreased immune response, lowered immune defenses, increased risk of autoimmune diseases, increased risk of becoming ill, protracted recovery times if you are unfortunately becoming ill, and also, like I said, risk of those autoimmune conditions or exacerbation of pre-existing autoimmune conditions. If you look at it from the diathesis stress perspective, heightened levels of stress can also facilitate the propagation of pre-existing genetic proclivity for autoimmune concerns. Even from the integumentary perspective, we can see hair loss or dull or brittle quality of body hair, brittle nails, dry skin, acne, and delayed tissue repair and wound healing. From a digestive health perspective, slow or weaker nutrient absorption, diarrhea or constipation, indigestion, bloating, pain or discomfort, acid exposures, ulcers, etc. In the reproductive milieu, we can see decreased hormone production, decreased libido, and even in those who are biologically female, increase in PMS symptoms. From the skeletal and connective tissue region, we've talked about increased concern for inflammation, so exacerbation of carpal tunnel syndrome or other connective tissue concerns, tension, aches and pains in the joints, muscle tightness, etc. So the impact of these kind of these multiple concerns here put such a stress on the system. One of the comments that we received said, sounds like COVID. It does have sort of a comprehensive system response in the sense that it will impact every part of your body. There's not one particular part of your body that is targeted more than the other, but it will do is bring about weaknesses or concerns that may be pre-existing, and then draw upon those to cause long-term concerns and difficulty. So if you have pre-existing health conditions like asthma, or if you're exposed to concerns that could exacerbate lung or breathing or shortness of breath concerns, or if you have multiple sclerosis, lupus, Lyme disease, or hypertension, hyperlipidemia, if these are not attributable solely to the impact of toxic stress, they can certainly be exacerbated by the presence of toxic stress. So we need to look at individual and personal factors, community factors, and as providers, making sure we're giving out appropriate education and information on managing these concerns, because the best thing we can do once we have these issues is start to manage them from a symptoms and a systems perspective. I want to see if Dr. Miller or Allie is available to just check in and see where we're at, because I don't want to take much more of anyone else's time if this is a good transition point.
Well, thank you, Dr. Anger, and we'll have time for questions at the end. If people have questions, please put them in the chat box, and then we'll come back to those. Next, we're going to hear from Dr. Krieger, Dr. Karen Krieger. She is a professor in the Department of Family and Geriatric Medicine at the University of Louisville School of Medicine and Director of Health Equity for the Health Sciences Center. She is a Louisville native. Her clinical practices include primary care services and HIV services. She is dedicated to educating both the public and medical professionals and students on diversity and inclusion topics, among other things. Welcome, Dr. Krieger.
Thank you very much, Dr. Miller. Let's see if I can pull up these slides here. There we go. So I would like to thank the foundation for allowing me to speak on unmasking the impact of toxic stress and discrimination on health outcomes. If you look at the background of this slide, it sort of pertains what I'm going to be speaking of. All these pieces are not on the same level, but they are fitting, and that's sort of like how we are when we are going through life. Let's see. We're going to talk about identifying the historical and current toxic exposures to marginalized populations. That was my piece on this presentation. And I've listed some of the major groups: African Americans, immigrants, LGBTQ+, the disabled, the age. But I was reminded last week when I was doing a presentation to international undergrads that being a marginalized population in itself doesn't include individuals that are in specific physical spaces. And so they reminded me that being Jewish in a community or in a room or a classroom, or being a Muslim or Buddhist, or being the only female that's in a classroom can also mean that you're in a marginalized community. I am approaching this topic from my experiences with a couple of different areas. A few months ago, I gave a presentation on domestic violence, and talking to physicians, you mostly stress, what does domestic violence look like? What are your signs and symptoms of physical, mental, emotional, and financial abuse? What are the laws in Kentucky governing your actions? But I became particularly interested in the recidivism of individuals that return to environments that were particularly hazardous to themselves or their families, either physically, mentally, emotionally, or financially. I also do some work in the Office of Diversity and Inclusion at the University of Louisville, and I'm very, very proud and pleased that those individuals have taken time to educate me over the years of some of the concepts I'm going to share with you today. So where we're going, for the next few minutes, I ask your indulgence, please. We're going to review possible residual historical effects of toxic stress and trauma on generations, and current toxic stress assaults on marginalized communities. So research from mass cultural and historical trauma affecting subsequent generations, we have lots and lots of examples, and lots of these have been studied. I've listed a few here of the effects of mass cultural and historical trauma. The Holodomor mass starvation of millions of Soviet Ukrainians from 1932 to 1933, the Khmer Rouge killings in Cambodia, the Rwandan genocide, the Holocaust, families and survivors, Native American residential schools, families and survivors in US, Canada, and Australia, the slavery of African Americans, and we have data derived from Union Army prisoners of war and their children from the Civil War. We're talking about generational trauma. We're talking about neuroplasticity, and we're talking about terms epigenetics that you may or may not have heard of. The first study in this area was in the 1960s. The title of the article, Fearful Mouse Memories Passed Down Through Mouse Descendants. What they did was take a group of mice and put them in a maze and acquaint them with the pleasant smell of acetylphenone, which smells like cherries and almonds. When the mice would find them, they would be very happy because it smelled like food, but they would receive a small electric shock. And eventually the animals learned to associate the scent with pain. They would shudder in the presence of the smell, even without the shock. What was very interesting is that this reaction was passed on to their pups. Never having encountered the acetylphenone in their lives, the first generation offspring exhibited increased sensitivity when induced to its smell, shuddering more markedly in its presence compared with the mice that had been conditioned to be startled by a different smell or that had never gone through any conditioning. And more astonishing was that this reaction to the smell of the cherries and almond in the third generation of the grandchildren of the original mice showed a reaction to this scent even without having been electroshocked before. So a growing body of evidence suggests trauma can be passed from one generation to the next. It can leave a chemical mark on a person's genes that can be passed down to future generations. It doesn't cause a genetic mutation, but it alters the mechanism of which the gene is expressed. This alteration is not genetic, but it's referred to as being epigenetic. This is toxic stress that is passed from one generation to the other. It is exploring the fact that we have genes. We've had the genome since 2003 now. So we know that we do have genes that can be turned on and off depending on what's happening in our environment. If a child grows up with an overload of toxic stress, their stress response genes are likely to be activated so that they are easily triggered by stressful conditions that don't affect those that are not grown up with the toxic stress. And even more importantly, this can be passed on to their children. Several factors such as stress, adrenal, gonadal hormones, neurotransmitters, as Dr. Andrea has spoken about, certain drugs, environmental stimulation, learning, and aging can change neuronal structures and functions. And these in turn can induce morphological alterations in brain areas. In neuromorphology, network alterations, changes in neuronal connectivity, and the generation or lack thereof of new neurons and the neurobiological balances. And we've got now, 60 years of work here. Neuroplasticity is the ability of the nervous system to change its activity in response to intrinsic or extrinsic stimuli, such as toxic stress, by reorganizing its structure, function, or connections. An emerging line of research is exploring how historical and cultural traumas affect survivors' children for generations to come. So what are other personal and current sources of toxic stress in our environments and those of our patients? And how does that affect our interactions as practitioners? Personal frames of reference of the people that come to us, whether they may have PTSD, what their ACEs score happens to be, implicit biases that we may have, or microaggressions that the patients may be facing. And then there are structural avenues of toxic stress in our environments and our culture, like redlining. This is a picture of a doctor's office in the 1920s in the South. I'm referring to personal frames of references of patients that you may have. Patients in their 90s, 80s, 70s, and 60s may remember there was a time of segregation in which going into the doctor's office as a person of color meant you went through the back doors, that you did not have equal access to services, that you were supposed to behave in a certain manner. And those personal frames of references are going to influence how your patients react to you and your staff when you render medical care. They will remember those times and that people really didn't go to the doctors because they didn't want to go through the back doors. And so when they presented, their prognosis was less than optimal because of the disease advancement. So if a person is called by their first name from your office and they're in their 70s, 80s, or 90s, they may experience some reactions of stress, toxic stress. Their blood pressures may go up that you may see because they weren't addressed by any sort of last name or title, Mr., Ms., Miss, or a professional title. In fact, they may have frames of reference in which that call by a white person may have been because they were the servant, the maid, or some other stressful situation in their memory. Post-traumatic stress syndrome, PTSD. Let's talk a minute about that. So I've taken some information lifted. This is certainly not enough for any diagnosis, but the beginning part of making the diagnosis from the DSM-5 is actual exposure to or threatened death, serious injury, or sexual violence in one or more of the following ways: directly experiencing the traumatic event, witnessing in person the event as it occurs to others, learning that the traumatic event occurred to a close family member or close friend. In cases of actual or threatened death of a family member or friend, the event must be accidental or violent in nature. So, how many mass shootings have we had in the US so far this year? As of May 30th of this year, which was the 150th day of our 2023, we had 263 mass shootings. A mass shooting is defined as involving more than 4 people. So if we had 263 incidences and you multiply that by a minimum of 4, and then you think of all the family members that were affected by their family member being either close to or involved in, or the first line responders that had to respond to this and their family members were worried. We have quite a few people in our country that are subjected, could possibly have PTSD. This past Monday, July 10th, was the 20th anniversary of the Srebrenica massacre. In 1995, 8,000 Bosniak, mainly Muslim boys and men, were shot in Bosnia by Serbian troops. And that town continues to this day to honor their dead. And family members are still receiving body parts as they're still finding mass graves and they're being unearthed and identifications are made. They still are subject to PTSD. As Dr. Anger has explained, in his synopsis, I'm just going to take this from the DSM-5 of post-traumatic stress. These individuals who have it may have persistent or exaggerated negative beliefs or expectations about themselves or others or the world. They may have persistent distorted cognitions about the cause or consequences of the event, blaming themselves or others for what happened. Persistent negative emotional states like horror, anger, guilt, or shame, markedly diminished interest or participation in significant activities. These individuals with PTSD having the effects of this toxic stress can express irritable behavior and angry outbursts with little or no provocation toward people and objects. They're expressing aggression, recklessness or self-destructive behaviors, hypervigilance, an exaggerated startle response, problems with concentration and sleep. Talking about ACEs, adverse childhood experiences. I like this cartoon. I'm afraid, said Rabbit. What are you afraid of? Asked Bear. I don't know. replied Rabbit. I just am. Then I'll sit with you until you're not afraid anymore, said Bear. We'll face it together. So most of our electronic medical record systems have ACEs for adults embedded, accessible to us as practitioners. You're going to find that it might be useful to you if you've got the patient who has multiple medical issues to go through ACEs with them and see if you can quantify some of the experiences that they've had. The first experiment or reporting of research on ACEs was in 1998, and they found a strong graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors for several causes of the leading causes of death in adults. Diabetes, hypertension, hyperlipidemia, obesity, our bread and butter as family docs in Kentucky. The ACEs questionnaire for adults is adapted from the work of the Kaiser Permanente and the Centers of Disease Control. I like this cartoon from Dr. Dan Siegel. The simplest way of defining trauma is that it's an experience that overwhelms our capacity to cope. So we develop maladaptive ways of working through our exposures to survive, whether we're in a household as children or whether we're adults as work or whether we're in Bosnia or any other country that is having significant impact or whether we are slaves in a country. So looking at the odds ratio of patients who have had more than 4 ACEs compared to those with no ACEs, individuals with 4 or more ACEs have an odds ratio of 7.8 for being victims of violence, whether it's intimate partner violence or sexual assault, an odds ratio of 8.1 for perpetrating violence, 4.5 for having PTSD, and a whopping 37.5 for suicide attempts, and almost 6 for STD occurrences. Another type of toxic stress is implicit bias. And it's a form of bias that occurs automatically and unintentionally, but nevertheless affects judgments, decisions, and behaviors. These are automatic reactions we have toward other people based on our past learning and expectations. It can be attitudes, stereotypes, and beliefs that are directed toward race, culture, ability, language, or gender. The good news is implicit biases can be mitigated with education. And the Harvard implicit bias study is something that I encourage everyone to periodically take. You'll be surprised at the results that you yourself unintentionally may be exposing your patients to. Another toxic stress that may affect marginalized populations includes microaggression, a statement, action, or incident regarded as an incidence of indirect, subtle, or could be unintentional discrimination against members of a marginalized group, such as a racial or ethnic minority. It can be indirect, subtle, or unintentional discrimination against members of this marginalized group. And there's a video that I'd like to share with you, and I hope Allie can help me with this so that I don't leave my slide set. I have to warn you, though, it has 2 words in it that I don't use in polite or unpolite language, but I felt the material within this video segment on YouTube warranted a little bit of toxic stress on our part to learn about microaggressions. Thank you, Allie.
Can you see the screen ready for the video?
Yes.
Okay,
Thank
I'll
you.
play it now.
For people who still don't think that microaggressions are a problem,
Oh, you're so well spoken.
just imagine instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland?
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
I'm just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV,
We have to keep the Redskins name. It's part of our culture and history.
or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Give me shopping advice.
I love Cher too.
And getting bit by mosquitoes every goddamn day,
Can I touch your hair?
multiple times a day,
So pretty. Can
Can I touch it,
your hair,
please?
please?
I want to touch it. Can I please?
is fucking annoying. And makes you want to go ballistic on those mosquitoes, which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares? Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try less challenging, Major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
Thank you very much, Allie, and forgive me, those online, if you were offended by some of the terminology that I didn't allow my children to say. I'm going to go back and share my screen to see if I can get back to my slides. There we go. So can you guys see that now?
We do.
Thank you. Now let's talk about another type of toxic stress, and I'm going to get into redlining. So redlining is an event that started in 1933 when the U.S. government created the Homeowners Loan Corporation to bolster the housing market and homeownership across the nation. It created these residential security maps, better known as redlining maps, to guide investment in U.S. cities. And because it was a federal law, every major city in our country has redlining neighborhoods. Historical practices such as redlining have resulted in poor, overcrowded housing, exposure to more severe levels of air pollution, which contribute to chronic disease. Redlined areas, when they were developed in 1933, and this process did not end until 1951, were restricted to industry, Black, immigrant, and low-income communities. So this is a map of redlining in Louisville. The red area at the top left of your screen represents Portland, Shawnee, Chickasaw areas, Algonquin of the city. The green and the blue over on your right represents Florida Forks and the beautiful park areas, the northeast part of our county. Zip codes 410, 1112 comprise an area of 3 miles radius where more than 121,000 people live, representing 51,000 plus families. If it were a city, it would be the third largest city in the state of Kentucky behind Louisville and Lexington. Only 40% of the population in this area have access to broadband internet. So if you're trying to do telemedicine to the population living in this area, as we discovered during COVID, it is a struggle. This area has the highest unemployment rate, highest childhood poverty rate in Jefferson County, lowest median income, the lowest educational attainment, the lowest life expectancy in years in Jefferson County, and the highest number of beta agonist prescriptions for asthma, because that's where the industry is as well. There are still, even though redlining officially ended in 1951, conventional effects of redlining. Refusal to provide delivery services in certain areas. Now, the west end of Louisville isn't the only redlined part in Jefferson County. Southwest Louisville also had a small contingency of redlining because we didn't have open housing to African Americans till 1963. And so a small carve out was made in the southwest portion, southeast portion of Jefferson County. And so getting delivery services can still be challenging, not to mention home health services for nursing care. Business loan denials, regardless of credit worthiness in the zip codes affected by redlining, still exist. Refusal to write property insurance policies or dropping property owners from insurance coverage altogether still happens. In reverse redlining in these areas, there are services that are offered to low income residents at higher prices because their zip codes are in these areas, such as for car insurance, that's based on your credit worthiness, but it also is influenced by your zip codes. People in these areas can have higher interest rates and excessive fees or inferior products, and you see a plethora of payday loan companies, cash advances, and expedited tax returns. So I have finished my portion, and I thank you for your attention, and I welcome your questions toward the end. Thank you very much.
And thank you, Dr. Krieger. Next, we're going to hear from Dr. Shilpa Lundy, the co-founder and executive director of the nonprofit Maternal Spotlight. Unfortunately, she has had some travel needs come up for work and can't be here in person today, but she was gracious enough to record her presentation ahead of time. Dr. Lundy is an advocate for creating systemic change to advance social justice in all areas of individual and population well-being. She is a research scientist with multidimensional training in health services, disparities, research methods, social policy, economics, social determinants of health, and public health. Let's watch her presentation now.
Thank you so much for having me here today. It's wonderful to be back as a panelist supporting the Foundation for a Healthy Kentucky. The last time I was here, I was discussing the relationship between social policy and health. Today, we'll be discussing toxic stress, maternal health, and patient-centered care. Now, it sounds like you've already heard a little bit about my background, so I'll just add that over the last several years, I've been working in two key areas. Some of you may know me from my work in public health consulting, as it included working with the Commonwealth of Kentucky. The other area I've been working in is in the maternal health research and nonprofit space. And I mention this to provide a bit of context around the perspective I have as I present on the topic of toxic stress. My presentation will cover three main areas. First, I'm going to begin by providing an overview of how toxic stress is considered when setting maternal health and maternal care experiences. This will, of course, include a discussion on racism, discrimination, and bias as a part of the patient experience. From there, I'll provide a few illustrations of how racism and bias exist in clinical care. And finally, I'll present a few considerations that might be useful for providers who are thinking through patient-centered opportunities to improve health. So let me first set the stage for why maternal health. A few years ago, I founded a research nonprofit dedicated to studying maternal care experiences, which are very much understudied. To give an example, we recently published a paper which illustrated how maternal health data and quality measures are infant-centric and do not fully allow us to understand the full range of burdens faced throughout a maternal health journey. However, if we were to take an expansive view and go beyond pregnancy and birth and focus on creating maternal-centric approaches, we find there are several other domains or experiences throughout the life cycle which influence health both immediately and in the long run. As many of us know, research on toxic stress highlights how early childhood experiences influence lifelong health outcomes. However, if we consider the maternal-child dyad and think through how stress influences the mother, it can open up the story a bit further. There are several frameworks which conceptualize the pathways between external factors, racism, stress, and health, some of which you may have discussed today already. The Developmental Origins of Health and Disease framework, which you may be familiar with, suggests that there are two histories of adversity that can contribute to poor child health outcomes. This means that in addition to traumatic events for a mother during childhood, a mother's experience of stress during the pregnancy itself can influence a child's development as well. Emerging evidence also suggests that exposure to vicarious racism or racism experienced by a caregiver is also associated with poor child health and development. Now, at this point, I'd like to take a moment to humanize this discussion by sharing some maternal health stories. These lived experiences take place across the maternal care journey and highlight the types of stress that can occur as it relates to the interaction with the healthcare system. I'll call out one in particular during the postpartum period in the bottom right corner, as it will relate to a topic I'll cover later. This story highlights how different histories of adversity, which I mentioned before, and trauma can influence the well-being for mother and child for years to come. She shares with us that she had a traumatic C-section, which brought on severe postpartum depression and PTSD. In every aspect of my pregnancy, birth, and postpartum, I was treated as a problem to be managed, not as a human being with my own desires. It set the stage for many years of struggle and suffering for me and my family. Now that we've heard about the maternal health perspective around toxic stress, I want to shift to discuss examples of racism and bias in clinical care. I'll begin with 3 examples from maternal health, but they have several parallels that can be seen in other care settings and among other patient subgroups. Beginning with the first one, the American College of OBGYNs, or ACOG, published a set of optimized care guidelines for postpartum health in 2018. They noted that the weeks following birth are a critical period for a woman and her infant and set the stage for long-term health and well-being. They called for care to expand upon requiring one follow-up visit after birth and advocated for a more comprehensive care plan aligned with the woman's individual needs throughout the postpartum year. Of course, this was a very positive step in creating more maternal-centric clinical recommendations for the postpartum year. However, I'd like to present the perspective written in a commentary about these recommendations by Scott and Davis, who highlighted the following. Our overall impression of the committee opinion, whether intentional or not, is the blatant omission of an explicit discussion of the underlying causes of postpartum inequalities. They go on to say that Black mothers and birthing people deserve care and to be cared for in the most optimal manner that fulfills their care needs and facilitates agency and self-efficacy during this service utilization. This is just one example of how recommendations from strong organizational entities may have unintended consequences when they do not explicitly address racial equity with a person-centered approach. The second example I'd like to discuss is around screening tools or algorithms which can be embedded with bias. Universal screening of women for depression is one strategy in maternal health to improve outcomes. However, Sroka and colleagues argued that it has been deployed without really understanding if a depression screening tool can capture exposure to other discrimination stressors which are known to impact Black women. Their study found that the screening tool under-identified women whose health was at risk and concluded that the tool really needs to be reconsidered to be more effective at improving Black maternal health outcomes. Next is an extreme example, but it comes from obstetrical racism, which is a concerning pattern of maltreatment of non-white pregnant women and includes a disregard for their birthing wishes. A study from the University of Colorado found that there has been a sharp rise in medically questionable inductions. The authors noted that obstetric care is being centered around the needs and preferences of white women. Finally, I'd like to zoom out and talk about implicit or unconscious bias and the patient-provider relationship. Here, implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. Now, there's a lot of research on this topic, but I'll conclude with saying that in healthcare, this unconscious bias might affect a provider's line of questioning, body language, or other subtle cues which may influence a patient's trust and their healthcare decision-making. So, knowing what we've covered thus far, it naturally begs the question, what can we do to address these issues? While I certainly can't provide a comprehensive list today, I'd like to touch upon an approach which many of you are familiar with, that of patient-centered care. Patient-centered care encourages active collaboration and shared decision-making between patients, families, and providers to design and manage a customized care plan. As I mentioned with the racism, discrimination, and bias examples, there are ample opportunities within a care interaction for communication to shape the quality of care experience to produce either a positive or a negative health outcome. And I'll just note that in maternal health, the quality of this relationship is not fully understood. The literature on this topic is still growing. However, it has been demonstrated that Blacks and Hispanics receive less information from their doctors to aid in decision-making compared to their counterparts. Some studies have found that medical mistrust, which is a patient's belief that providers do not act in their best interest, might be mitigated with patient-centered communication skills, such as confirming if questions or concerns have been adequately addressed during an appointment. In maternal health, further research is required to better understand the kinds of provider behaviors that women perceive to be discriminatory. Similarly, this type of research is still growing in other parts of health. However, shared decision-making tools, or tools which can help patients to feel empowered and able to self-advocate, might be one part of a larger effort which can be integrated into intentionally strengthening the patient-provider relationship. One example of this tool could look like a postpartum care plan tool, which allows the patient to talk to their prenatal care provider about their long-term health concerns and goals. Thank you so much for having me join into your conversation today. If you have any questions, please reach out to me at shilpa@maternalspotlight.org. I'd love to have the opportunity to meet you and learn more about your interest in these topics.
Okay, and we now have time for our panelists to answer any questions you may have. Just add them now to the chat box. If you have any questions for Dr. Lundy, we will do our best to get those answers back to you at a later time.
Yep, feel free to use the chat box or the Q&A option. I'll give us just a minute here to see if we have any.
And I'll direct a question to Dr. Enger while we're waiting for other people. Having spent my medical career in Appalachia, I was wondering if that also could be seen as a factor for causing toxic stress, simply living in Appalachia.
just simply by existing in that environment. It really, there's not been, as far as I've seen, any one particular geography that has said this is the region or this is a hotbed, but we do see that in environments where there is reduced access to medical care, reduced access to economic diversity, lower income, education limits, et cetera. So those types of variables that can be present in the Appalachian region can certainly exacerbate those factors, but it's not linked because it's Appalachia. So there are people who are thriving in that environment and not experiencing toxic stress because of community variables that are sort of mitigating some of those factors. But it is an environment that definitely has several factors simultaneously.
I saw a question to pop up about food insecurity and the occurrence of toxic stress. That was one of the studies that I had listed in my references. People that were exposed to extreme starvation, such as the Ukrainian Soviets, people in Africa, their genomic turn-ons made it so that subsequent generations seem to have higher incidences of hyperlipidemia and obesity and diabetes. And so that's how the food insecurity in the epigenetic research phase speaks to that. That those experiences of the parents living through that influences partially behavior, food hoarding, trying to hold on to food, and maybe getting their children to eat anything, not just the proper foods, but it also responds to the biochemical changes that happen genetically. Not changing the genetics, but changing the turn on of the genes because of the exposures through that starvation period. How they kept, how they were able to eat and metabolize the foods that they took in.
Dr. Krieger, we have a question for you. Someone wants to know if you can speak to children being generally a marginalized population.
Give me that question again. I'm not sure understood.
Can Dr. Krieger speak to children being generally a marginalized population?
Generally in a marginalized population? Oh, yeah.
Yeah.
Yeah. Okay, so let's say that you have a BIPOC child who grew up in an environment, church, school, the community, in which they were viewed as equal by BIPOC and non-BIPOC individuals. And then that child goes to college at a school that is 98% white and maybe in an environment in which enlightenment isn't there. They have a hard time assimilating because they're used to being treated as an equal and they're finding themselves in environments that are not equal. There was an article in the Courier Journal this past, I think it was Sunday, about the cultural center at the University of Louisville campus and how important it was to the children. Sorry, I'm old, I can use that term, to the students going to find a home at the campus that is primarily white when they were either immigrants or BIPOC, and that cultural center, the importance of their acclimation to their education. And so, yeah, growing up in a marginalized, even though as parents try to protect and provide experiences that foster resiliency, they leave the nest. And we still have to worry about them and support them in those efforts. And as educators of secondary education, we have to be very conscious that we're being entrusted with those students. Thanks for that question.
I'll give it one more minute. So in regards to our discussion a minute ago about, food insecurity and stuff, we do have someone in the chat saying that they're looking for a partner to integrate their program with patient-centered care. I don't know if any of our panelists want to jump in, but if not, I can also connect you with Dr. Lundy and see if she has any ideas for that as well.
Well, I know in Jefferson County, there are several initiatives to help with food insecurity in Jefferson County. Fresh Stop a few years ago wrote prescriptions for diabetic children so that they could get fresh fruits and vegetables from their organization. And then they changed the prescriptions to the geriatric population. And the state has several farmers markets and ways of getting food to people. So yeah, we have lots of avenues. Unfortunately, there's always too much work to be done. So I would suggest to the people that are involved, perhaps they could work with the providers in their area so that that could be an established pipeline, and they could come up with a way to supplement what's there or develop a new way of getting food to the patients that need it.
We've got a suggestion in the chat about university students, and it's about campus candor and race and class. And there's a link for that if anyone would like to click on that.
Thank you for sharing that.
Okay, well, if there are no more questions, thank you so much to our speakers today for sharing your time and expertise. We really appreciate it so much. I know it's past 5 o'clock during the week. Oh, we do have something popping up. Someone wants to know if there are any opportunities to collaborate with Dr. Krieger.
Yeah, let me give you a phone number to the admin office, 502-852-7159. My clinical office, that would be difficult, but the admin office should be able to connect you with me. Thank you. I look forward to hearing from you.
And we have several comments in the chat of excellent presentations and thank you. And I mirror that. You both have done an excellent job, as did Dr. Lundy, and I'll be reaching out to her to thank her as well. And thank you to Dr. Miller for being such a great moderator. I really appreciate it. And this was recorded today, so it will be in your inbox. Share it with whoever you like, whoever you think it would be appropriate to see. And yeah, just thank you so much and have a great rest of the evening.